Next is the visual system. First, let's take a look at the external anatomy of the eye. First is the eyebrows. The eyebrows sit above the eye opening, or really above the palpebral fissure, which is the gap between the two eyelids. And these are actually here to perform shading of the eye, so from very, very bright light, but also to help inhibit sweat and other molecules from dripping down the face and into the actual eye opening, which can be irritating. Now, the external eye here, the eyelids are actually known as palpebrae. So here they are on the actual surface anatomy. Here is the actual surface anatomy of the palpebrae themselves on this cross section of the eye, where here we're looking at the actual eyeball itself, the eyelids, and then the palpebral fissure, the gap between the two eyelids. The gap between the two eyelids is this space right in here. So we have a superior palpebrae and an inferior palpebrae. Now we have 5 layers actually to the tissues of the eye. First we have the skin on the surface here and here. The next layer is actually going to be connective tissue, and remember that connective tissue has a lot of fat within it, and that's what this yellow material is through here. The next layer is this area here, the tarsal plate. This actually helps to maintain the shape of the eyelid, and it also contains the Meibomian gland, which is actually going to be a fat or really wax-producing gland as well. The next one is actually going to be this right here. This is actually skeletal muscle, and this is the orbicularis oculi muscle that actually will close the eye and squint the eye, but it will also contribute to some of the thickness and structure of the eye itself. The last layer is this area right in here. This is the palpebral conjunctiva. The palpebral conjunctiva is actually a thin layer of mucous membrane that will actually help to lubricate the eye and decrease friction between the outer surface of the eye here and the inner surface of the eyelid. So this is the palpebral conjunctiva here. We actually will have a bulbar conjunctiva that will actually cover the whiter portions of the eyes, or what we call the sclera, which is the white of the eyes. And this bulbar conjunctiva is the red blood vessels that you actually can see on the surface of the eye. Now, the canthi are the corners of the eye here and here. Contained within the medial canthi is the caruncle, and the caruncle is actually going to be an area, a modified sweat gland that will actually help again to lubricate the eye, provide some sweat or lubrication, as well as some fats for the surface of the eye to actually help trap bacteria and wash out other particles that may enter the eye. So then we get to the eyelashes, and the eyelashes is either a double or a triple layer of hairs extending from the superior and inferior palpebrae right at the tip. Now, these actually will have glands on them as well. We have ciliary glands, which are actually going to be modified sweat glands, and these actually empty into the base of the hair follicles to help lubricate and keep the hair follicles healthy. And then we actually have Meibomian glands, which are within the within the tarsal plate right here. So this is the actual Meibomian gland, and again these produce sebum, which is really a waxy fatty material that will again help to keep not only our palpebrae healthy with a nice healthy fat and moisture for the skin, but also for the eye as well. So conjunctiva I kind of already mentioned, but we have the palpebral conjunctiva here, again the bulbar conjunctival here, and again the bulbar conjunctiva covers all of the white part of the eye. The only part of the eye that does not have the bulbar conjunctiva is actually this area here, and this is going to be the cornea. This is the transparent area on the eye where we can actually see the underlying iris and the pupil through there. Now again, the function of the palpebral conjunctiva as well as the bulbar conjunctiva is to provide some lubrication, but also will provide blood supply to the outer sections of the eye, So it'll have some nutrients, but it'll also have the ability to fight off things like infection. Um, so conjunctivitis, pink eye that you might have heard of, which is really specifically bacterial conjunctivitis, is an inflammation here of the palpebral as well as bulbar conjunctivitis that we can actually see in the forms of reddening of the eyes. Then we look at this outer portion of the eye, the sclera. Again, so the white part of the eye here is the sclera. Now, we actually can see the bulbar conjunctiva, these little red lines through here. That is that thin mucous membrane that is covering the surface of the sclera here as well. So sclera with the superimposed over the top of it bulbar conjunctiva. Now, the function of the sclera is actually, it's going to be our major structure that is holding our eye together. So it provides the shape, it provides protection for internal structures, but it also provides attachment points for muscles that will actually be on the posterior, lateral, and well superior and inferior aspects of the eye. Now, the other area that we can see here is the cornea. This area here, where it is actually transparent, is the cornea. Now, we actually will see the iris, the colored portion of the eye, as well as the pupil through the cornea. So if we look here on the cross section, again, we have the sclera, this white area here, okay? When it becomes transparent, this area here, this is cornea. It is congruent with essentially the sclera, but once we get up here and it's transparent, it is actually going to be the cornea itself. Now, the sclera and the cornea are actually made up of similar material, but the sclera is actually made up of very, very thick fibers of collagen, and so it will provide that white color that might be similar to a tendon or actually be apparent in other dense collagenous connective tissues. So the sclera is going to be white. Again, the cornea is actually going to be transparent, and it is actually made up of collagen again, but now very, very thin fibers. It also has a lot of proteoglycans, and proteoglycans are there to trap water. We saw these in joint surfaces, specifically things like the meniscus or the disc, and the proteoglycans trap water. Now, as light actually passes through a translucent surface with water, light will bend. And this is what is known as refraction. Refraction is actually going to take place at multiple places throughout the eye, but you can think of looking into a swimming pool, the bending of light that takes place. If you stick your arm into a swimming pool, you'll see it as if your arm actually bends as it extends into the pool, but really it doesn't. It is the light that is actually bending. So again, through the cornea, here, okay, we can actually see the underlying iris, which is the pigmented part of the eye, and then we see the pupil, the gap with it is going to be constricted or enlarged to allow more or less light. So there again is the pupil. The outermost surface of the cornea is actually protected by a stratified squamous epithelium, again, because it is has the possibility of actually being damaged by outer surfaces or outer particles, smoke, dust, etc. And so that protection of the stratified squamous epithelium is present on the sclera as well as the cornea. So now if we look at the lacrimal apparatus, this is actually our tear gland. So the lacrimal gland here is where our tears are produced. This is at the superior lateral aspect of each eye. Now, from the lacrimal gland, we have multiple ducts that will actually leave from that lacrimal gland and enter into the actual surface of the eye. So tears are going to be produced, and they're actually going to be washed from lateral towards the medial aspect of the eye. And this is so that we wash particles off of the surface of the eye and in one direction. You can think about washing your car, right? You don't just spray at it in any which direction. Oftentimes you're spraying from one side to another to try and move that material, whatever happens to be on the surface of the car, in this case the eye, from one area to another. Now, once the tears actually reach this medial aspect, they actually encounter the puncta, and these are going to be tiny little holes that will actually allow the tears to escape into the lacrimal canaliculi. And the lacrimal canaliculi will actually carry tears out of the eye and actually towards the lacrimal sac and eventually towards the nose. This is essentially a way to drain the tears from the eye that, especially in time periods when there is not an excessive amount of tears produced, it will wash the eye, continuously cleaning the eye, but draining out without it actually washing down our faces and when we're crying. Now, as it washes in here, it goes into the lacrimal sac and down through the nasolacrimal duct. Remember that we had the nasolacrimal foramen present on the bony anatomy. This is actually where that nasolacrimal sac actually runs, and it actually connects between the eye, the orbit, okay, the eye socket, and the nasal cavity. So this actually allows for tears to enter the nasal cavity and actually exit through there. So when we cry, etc., we'll actually produce excessive amounts of tears, and that will actually be draining out through the nose that we can actually see by having a runny nose. So if we look at the muscles of the eye, we have 6 different muscles of the eye that we learned within our muscle section of anatomy. So if we look first here at this lower diagram, we start back here at the common tendon for many of our rectus muscles of the eye. They are actually originating off of the sphenoid bone, but really just adjacent the optic nerve, and really that optic canal is really where it attaches. So let's first look at lateral rectus. Now again, lateral rectus runs on the lateral aspect of the eye, so it's running from the lateral common tendon here all the way to the lateral and posterior aspect of the sclera cornea junction. Now, when this contracts, it will actually abduct the eye or laterally deviate the eye, looking towards the temple. This is actually accomplished through cranial nerve 6, the abducens nerve. This is the only function, really, of the abducens nerve is to abduct the eye. So abducens abduct the eye, lateral rectus. Now, not visualized actually on this one here, but medial rectus will actually be present here. So this is looking from the superior aspect now. We look here, it again comes from the common annular tendon, and it goes to that posterior medial aspect of the sclerocorneal junction. This one, again, when it contracts, it will actually adduct the eye, making the eye look towards the nose. This is actually done by cranial nerve 3, the oculomotor nerve. We will actually have 4 other muscles that would be controlled by the oculomotor nerve. Superior rectus, again going back to this lower diagram, again originates from our common annular tendon, and it inserts at the superior aspect of the sclerocorneal junction. This one, again, when it contracts, will now elevate the eye, or looking up towards the forehead. This, again, is controlled by cranial nerve 3, the oculomotor nerve, and so we will have elevation of the eye as well as medial deviation or adduction of the eye done by the oculomotor nerve, while our cranial nerve 6, the abducens, will actually run lateral rectus and will laterally deviate or abduct the eye, abduct the eye. So then we look at inferior rectus, and inferior rectus is running right along here, again originating from our common annular tendon, and again going to now the inferior aspect of the sclerocorneal junction. This now depresses the eye, meaning that it actually causes deviation of the eye inferior, or looking down towards the toes. Now this again is controlled by cranial nerve 3, the oculomotor nerve, and so this is our third movement that actually involves the oculomotor nerve. The first being superior rectus, the second one being medial rectus, and now inferior rectus. I'm going to jump ahead here and actually do inferior oblique so that we finish the oculomotor nerve. So the inferior oblique actually starts on the orbital surface of the maxilla, so actually towards the medial surface of the eye. So starting actually on the opposite side here of this one. So this actually then goes to the inferior aspect of the eye and actually wraps around to the lateral aspect of the posterior sclera. Now, When this one actually contracts, it'll actually elevate, so looking up towards the forehead, but it will also abduct, looking more laterally as this one contracts. This again is done by cranial nerve 3, the oculomotor nerve. So we have 3 muscle movements that will actually occur using the oculomotor nerve. The last muscle is superior oblique. And the superior oblique actually originates posteriorly again, but now it's not off this common annular tendon, it's actually off of the sphenoid body itself. It actually comes through and courses around and goes through a pulley. This pulley up in here is known as the trochlea, and the trochlea essentially changes the orientation of the pull. So instead of being from superior towards here, it now actually will come at as an angle, okay, that you can actually see here. So it'll actually come at as a 90-degree angled pull to the eye. Now, just like the inferior oblique, instead of producing a isolated single movement, this will actually depress, so gazing towards the cheek or down towards the toes, but it will also abduct the eye. So if you notice, both obliques actually make our eyes look more laterally, but each one will either make us look superior or inferior as well. So the superior oblique actually makes us look inferior, whereas the inferior oblique actually makes us look superior. So if we look at the actual gross anatomy of the eye, so we've cut away the lateral aspect of the orbit here and highlighted each of the individual muscles in purple. So starting at the superior aspect, superior rectus again, attaching that common annular tendon to the superior sclerocorneal junction. Inferior rectus, common tendon to the inferior sclerocorneal junction. Medial rectus actually behind, not easily visualized, but there's a little bit of purple here attaching to the opposite side that we can actually see. Lateral rectus again, common annular tendon attaching now to that lateral sclerocorneal junction. Each of these does what they say, okay? Superior rectus makes us look superior. Inferior rectus makes us look inferior. Medial rectus makes us look medial. Lateral rectus makes us look lateral. The only change is to these obliques. And again, remember that both obliques make us look laterally because a lot more of our world is out to the sides of our body than it is towards our nose. So lateral, or sorry, both of our obliques will have us look more laterally. So if we look here, the inferior oblique, remember it's circling around from the maxilla, medial more maxilla here, circling around to the posterior and lateral aspect of the eyeball itself, and when it contracts, it'll actually cause us to look up as well as lateral. The superior oblique, originating now posterior here on the sphenoid, comes through the trochlea, that pulley system, coming back and across, again now going to the superior and lateral aspect of the eyeball. And as it contracts, it will actually make us look inferior as well as lateral.